Hello, welcome, and thanks for joining us to help choose home when care is needed, a podcast all about the benefits, value, and safety of receiving care and services in the one place that feels most comfortable, wherever it is that the person needing care calls home. I'm your host, Marilee Orsini, and I've been involved in healthcare at home since 1981. Before we meet today's guest, a brief thank you to our sponsors and partners, the National Association for Home Care and Hospice, Access, and Core Cubed. Today's episode is number 13 of season 4, and our guest today is Dr. Alice Bonner. She is a nurse practitioner who has been practicing for over 30 years now and currently is the director of the Johns Hopkins University School of Nursing CAPABLE program. She also serves as a senior advisor for aging at the Institute for Healthcare Improvement. Please help me, won't you? And welcome Dr. Alice Bonner to Help Choose Home. First, Alice, I just want to thank you so much for your time today. It is really a pleasure to have you on the show. And first, I want to know, tell me all about the CAPABLE program.
Oh, gosh. Well, first of all, thank you for inviting me to be with you today and have this conversation. CAPABLE stands for Community Aging in Place, Advancing Better Living for Elders. And it's such a long name that's why we call it CAPABLE, and we don't say it every time. But, you can tell from the name that this is a program about supporting one another, all of us supporting each other in our communities, in our neighborhoods, where we've grown up and where we live, if that's the place that we want to be as we grow older. And, some of the research when we've talked to older people, whether they're in their 60s, 70s, 80s, or beyond that, when we say to people, what's most important to you? What's important about your health and your quality of life? People over and over, 90% of people say, I really want to grow old in my home where I've been. And, some of that is because of the familiarity with the neighborhood. The pharmacist, the person at the post office, the person at the grocery store. And those are relationships that have been traditionally very important to all of us. So that's really how CAPABLE started. It began with Dr. Sarah Zanton, who's a nurse and a nurse practitioner and a researcher. And she and her colleague, Dr. Laura Gitlin, who's also a researcher, over 10 years ago came up with this idea because Sarah, as a nurse, was going into people's homes and doing home care and doing home health. And she recognized that a lot of what was happening was people were having to leave their homes because of things that were modifiable or fixable. And so, she figured out that if you thought about a registered nurse and an occupational therapist, or sometimes we just call them an OT, and a handy person who can do modifications and, fix up the environment, if those people go into an older person's home together and really listen to that older person and what's important to that older person and what matters most to them, they can create over 4 to 5 months a nice program with clear goals that the older person sets and a care or action plan that they would like to follow. And then, at the end, they look back and see what they've been able to accomplish. And the results have been quite remarkable over time.
And I would love for you to talk to me about those results, because it seems as if right now there is legislation that is trying to do something similar to what CAPABLE does, but on a national scale.
Yes, so it's a good point that you're making. We have a relatively new administration in Washington and in the White House, and a number of new people in Congress, and certainly at the state legislatures, the same thing. We have new faces and new ideas and innovation going on. And one of the big areas that's been a focus has been on home and community-based programs. I know that you have a background in home care. You and I were talking about that before we started. And, there's a lot of people now, probably more than we've seen in the past, who have gotten involved with home health and home care. We even have hospital at home programs. We have one out of Johns Hopkins University in Baltimore, Maryland, for example, and there's other replications around the country. We have nursing homes that are providing skilled care, and some of those individuals are receiving that type of care in their own home instead of moving to a nursing home. So, to deliver the kind of care and support that not only older people, but also people with disabilities or people who have certain challenges to getting around, whether that's, walking or other kinds of transportation to get to activities that they really enjoy. Home care is about addressing all of those, what we call social determinants of health. And so social determinants of health means, not just treating somebody's medical conditions or diagnoses, but if transportation is a challenge, how can we solve for that? If finances are a challenge, what are the opportunities and possible ways to address those issues? If medications are an issue, and for some older people, they're on 9 or 15 or 20 or more medications. And so there's opportunities there to go in and sort of talk through everything and see if the older person might want to come off of some of those medications and would like to talk to their primary care provider about that. And that's a lot of what CAPABLE does, because the registered nurse, has a strong background in how to review the medications, how to ask the older person questions about how they're feeling, and how to encourage them to talk to their primary care provider about any medication questions.
Is there a way for the CAPABLE program and its concept and in its practice to be applied in other states or in other ways?
So that's a great question. And the answer is absolutely. And so there's a few different paths that we're pursuing now. And we love to share this with the audience who's tuning into this program because every single letter and every single phone call that people make to their senator, to their congressmen, congresswomen, to their state legislators, those calls matter. They really matter. And so you're a constituent in a particular region. And, it's important if you think that a program like this could be helpful and supportive for older people and individuals with disabilities in your community, let people know about that. So to your point right now, there is legislation that's being drafted, and there are groups within the congressional system, for example, the Ways and Means Committee, they periodically come up with proposals and bills that, they might put forward, or that one of the senators or congresspeople might put forward. So that's one way that CAPABLE can get into the system, would be if we actually looked to change some of the systems within Medicare, for example, or within Medicaid. Within Medicaid, so again, just to be clear for folks in the audience, Medicare is the federal system, the national system of health insurance that, people usually sign on to when they turn 65 and sometimes earlier. And Medicaid is for low-income people of any age who need support. And a part of that is also includes the states having health plans that are for individuals who are on Medicaid, for example. And so, through our work and the work of other people around the country, we talk frequently with Medicaid programs in lots of different states. And we encourage them to think about ways they would add CAPABLE into their program for Medicaid recipients, so that anyone who was eligible for CAPABLE could have access to the program. So the state of Massachusetts actually put it into their waiver a couple of years ago. So they're just starting now to enroll people in Massachusetts, and that's the first waiver program. We have at least a couple more states who have put it in their submission to have it covered in their Medicaid waiver. So we could have a couple more states pretty soon who cover CAPABLE as a as a service that they pay for, the state pays for. So there's activity there. There are some state divisions on aging, which is separate from Medicaid. And sometimes the divisions on aging have ways they can combine state funding with federal funding. For example, the funding we get through the Older Americans Act. So anyway, that's probably more information than you wanted in response. But the other way we are approaching this is on the Medicare side, so the federal side of things. We have, traditional Medicare, which lots of people listening in might have. And we also have a growing group of people who have Medicare Advantage or health plans that are those types of plans. And so Medicare Advantage is able to put Capable in right now, today, as a supplemental benefit. So we have had Medicare Advantage plans that have done that, and we have a lot that we're talking to that are very interested. I spoke to one this morning, for example. They're very interested in doing that. We also have organizations around the country that go by lots of different names, and it sounds like alphabet soup, but we sometimes talk about ACOs, which stands for Accountable Care Organizations. And accountable care organizations can also build Capable into the services that they deliver. They have to cover the cost, but the return on investment, you asked earlier about the outcomes, from a cost perspective. If you're running a big hospital system or you're running a big group practice, a primary care practice, you can invest in Capable, and over just a very short period of time, you'll start to see a return on that investment, which means the program not only pays for itself, but you end up saving money for the people that you cover if you're covering people in a health plan or a value-based plan of, payers and providers together. So it's kind of complicated now because we have so many new models, but suffice it to say that Capable is the type of program that there's a lot of interest on the part of health systems, hospitals, practices, clinics, nursing homes, and assisted living. All of these different sectors are thinking, well, how could this work with everything else that we provide? Because ultimately, what I think all of us would like to see, we're all getting older, there's no stopping that. But I think what we'd like to see is a comprehensive continuum of care so that wherever you are and whatever's happening with you and your health and your quality of life and whatever you're looking for, whatever you want to be the outcome for yourself, we've got a system where there's no gaps. There's no big, places where people fall into a black hole and, disappear. We don't want that kind of system. We want an infrastructure and a comprehensive program where people are covered throughout their lives.
Wow. You have just supported one of my continuing thoughts is that we have such a complicated healthcare delivery system right now. So you mentioned cost as one factor that the Capable program is showing lower cost. But what about other outcomes? What kind of measurements are you doing that show better outcomes for the patients that have participated in the Capable program?
Right. And I'm so glad you mentioned that because, the top 10 outcomes that are important are all clinical outcomes. It has to do with exactly the way you just said it. It's what's important to the person and, what do those outcomes look like? And it's a good question because any system that's thinking about starting a Capable model or site, that's exactly the question that they ask, which is the right question. So we have data from years of randomized controlled trials and other studies that have been very rigorously conducted and written up in very, well-respected journals like Health Affairs and JAMA Internal Medicine and things like that. And the outcomes that have been most remarkable have been that people don't wind up in the hospital readmitted or admitted to the hospital when it can be avoided. So we're talking about avoidable, unnecessary hospital admissions and readmissions. So those numbers go down. Emergency room visits go down. And, I don't know anyone who says, I'd love to spend 12 hours in the emergency room today. If you need to be there, of course, but preventing the need for the emergency room visit is really what Capable has done preventing, the numbers of surgical or specialty visits, not surgery, but specialty visits, those numbers go down as well. The only thing that really goes up a little bit is home health and home care services. And if you think about it, well, of course, that makes sense because the person's spending more time in the home and they want to receive those services in the home. In terms of other clinical outcomes, we don't have a lot of data on reducing falls, but anecdotally, we believe that the numbers of injurious falls where someone gets a fracture, for example, those have gone down. We have some data on depression. So depression scores improve, meaning people are less depressed. We know that pain improves, so people have less pain and they're able to do more activities. The one characteristic that's very important for people to be eligible for Capable is that they have to have difficulty with at least one activity of daily living. And activities of daily living are things like walking, dressing, eating a meal, getting on and off the toilet, in and out of bed, those kinds of things. And so when people start Capable, they have self-described difficulty with 1, 2, or 3 of those activities of daily living, sometimes even 4 or 5. And over time, what we know from the data is that people express less difficulty with a lot of those ADLs when they go through Capable. So it's not that they don't need any help, but they need a lot less help. And in some cases, they really don't need help anymore with some of these activities. So, things that people tell us that are reported, and we have testimonials, we have videos, we have letters that they've written to the program, and we can share those things if people are interested. But they say things like, if I had 10,000 tongues, I could not say enough about how the Capable program has changed my life and, improved my quality of life. People say things like, I literally have not gotten in and out of the shower in the last year. And now I can get in and out of the shower safely and take a shower. And, things like that, until you've been somebody who couldn't take a shower, that those don't necessarily ring true as being important. But when you can't do those things that are personal care, it can really make a difference in your life. So people talk about those things. People talk about events that they are just finally able to do again, like going to their granddaughter's soccer game or going to the wedding of, their nephew, or just, family events, or, playing cards once a week with your friends. And again, I know that sounds like, well, that doesn't sound like healthcare, but it is part of our quality of life. And health is not all medical. So those are the kinds of things that we've heard about where Capable really makes a difference. Yeah.
Thank you very much for that. I'm going to switch gears just a moment and ask you about the Institute for Healthcare Improvement. You have been a nurse practitioner for over 30 years and obviously very, very well integrated into the healthcare delivery system. So talk to me about your role as senior advisor for aging there and how you see that role and your role at Capable emerging for the future of healthcare in America.
Well, thank you for the question. And the Institute for Healthcare Improvement, or IHI, has been around for about 30 years. Dr. Don Berwick has been, one of the senior leaders for much of that time. And, 30 years ago, quality improvement and quality improvement programs were not very well known and not very well scaled and spread. And now quality improvement is, as I'm sure you know, a huge part of healthcare across settings, across, hospitals, nursing homes, home care, really every setting, and public health as well. So age-friendly health systems is where I spend most of my time as senior advisor for aging. And age-friendly health systems talks about promoting, health systems where every person at every age is going to get evidence-based, comprehensive, age-friendly care and support. And, we have a framework for that, which includes, that it, whatever system of care is in place, it does no harms and it's evidence-based and it's based on what the older person, what really matters to them. We call that the what matters question. So age-friendly is based on 4 M's, 4 topics or categories, each of which starts with M. So it's what matters. That's the first M. Medications. That's the second. Mentation, or the mind. And that's the third. and mobility. And that's the fourth. So those are 4 M's, 4 areas of care and support that have been and are always important to older people, whatever setting they're in. So the question is, well, how do we measure that? How do we figure out if older people are getting age-friendly care? And what IHI has done is work with the John A. Hartford Foundation that has funded a lot of this age-friendly work, not only with IHI, but other organizations as well. And we've all developed tools and resources and guides. We've written guides that help organizations to know how to approach the 4 M's. How do you measure mobility? How do you demonstrate when somebody's mobility has improved or gotten worse? How do you capture the interventions or the things that you want to do with the older person to help address any issues within each of those 4 M's? And a lot of it is about, building a team, communicating among the team members, documenting in a place where everyone can access the information. And always, 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 it's about listening to an older person and sharing what they think is important to them. Because it's not about what I think as a nurse. That's not what matters. It's about what matters to the older person. So, they started about 4 or 5 years ago with Age Friendly, and they started with 5 pioneer health systems. And those pioneers developed a lot of these guides and resources, et cetera. And then over time, we brought more and more organizations into the age-friendly movement. And now it is a big national movement. I think we have 2,400 health systems, and that includes about 350 nursing homes, and then a bunch of hospitals and ambulatory practices and convenient care clinics, et cetera. So, to go from just 5 to up to 2,400 over a short period of time, we think demonstrates that people understand the importance of age-friendly care. We've also connected with our colleagues in public health. So there's an organization called Trust for America's Health, or TIFA. They're based in Washington, D.C. They do a lot of work on age-friendly health systems and public health, and we have some new work with them going forward. So, we think there's still a lot of potential. It is a national movement, and we want organizations to be able to be recognized for meeting the criteria within all 4 of those M's, that they're working on those things, and that a hospital or a nursing home or a clinic could get recognized by IHI as being an age-friendly health system. So we have a recognition process for that as well. And then there's also age-friendly communities, which is a separate movement, which is also really important. So, being recognized for being an age-friendly city or town or municipality or county, those things are really, really important too. And they fit together very nicely.
Well, I don't know about the listeners, but I certainly feel so much better knowing that you're where you are and that you are so interested in making this a better place for a better nation for us to age in. Our time, it always passes so quickly, but is there anything that I have not asked you that you would like to talk about today?
Well, I would just ask the audience members to think about ways that they can continue to contribute. I'm guessing if they're tuning into this podcast, they're interested in these topic areas. And, this movement for age friendly and the movement with the CAPABLE program, they would not have gotten as far as they have if it weren't for the support and the advocacy on the part of people like all of your listeners. So, this is not something that people like you and I are going to make or break. This is going to be something that we need everybody to participate in. There's no experts here. We're all experts. I'm 64, so I'm thinking now, well, I'm one of these people in their 60s, so I can, bring that perspective too. And everybody's perspective is important. So I would just encourage people, take action, write a letter, make a phone call, talk to your friends and your colleagues, pick up the phone and they can contact you, I'm sure, but, you can certainly contact me if anybody's interested in participating. We'd love to speak with them.
Thank you so much, Dr. Bonner. Just a wonderful, wonderful information chock full call today. So I really appreciate your time and I wish you the very best. And let's hope that we all in the future can look back and say we do live in an age-friendly country as we're getting older. So thank you very much.
Great. Thank you for having me.
Thank you so much for listening today, and a special thanks to our sponsors and partners, the National Association for Home Care and Hospice, Access, and CoreCubed. If you've not done so already, please subscribe to our podcast and take the time to leave a review on Apple Podcast. We are now also on Spotify and most other places where you find podcasts. Like and follow us on social media, and join us, won't you, to spread the word and help choose home when care is needed.